So here we go, case number 3. We have a 47-year-old man admitted with hypoxemia, kaletra. This question is about kaletra. He was started on kaletra and Plaquenil. This is early on in the season, but he continued to decline. What is not true about kaletra? There are the answers. Which is not true? Okay, so look through it. Okay, which one do you think it is? Give you another 10 seconds. Okay, so let's see some of these slides. So there are basically 2 studies to look at. A trial of lopinavir, ritonavir in adults hospitalized with severe COVID pneumonia. About 200 patients were studied. This is from China now. This is really what knocked kaletra off when we were using it early on, or it was being used early on in COVID cases. And if you look, days from the illness onset to randomization was on average 13 days. There were quite a bit of earlier treatment, but that was less than or equal to 12 days. You can see 45% of each group. But the average median, or the median number, was 13 days. The 28-day mortality was not different between the kaletra group and the standard of care. And the time to clinical improvement also was similar. But look at the ICU length of stay. In the kaletra, it was 6 days versus 11 days. Duration of mechanical ventilation, oxygen support, hospital stay. Everything trended towards being better in the kaletra group, and yet we discarded kaletra based on this study. The second study that's worth mentioning is the triple combo of interferon beta, 1 beta, lopinavir, and ribavirin in the treatment. And they compared to about 127 patients. They compared 86 patients in the combination group and 41 in the control group. The control group were just kaletra monotherapy. And look at the numbers here. It definitely improved with the combination group, but interestingly enough, these are patients mostly started less than 7 days since symptoms started. But the takeaway message for me was the 30-day mortality, even in the control group, kaletra, was 0. 41 patients. These are younger patients. The average age was 50s. But still, the mortality is 0. Why are we not using kaletra anymore? It's interesting. Treated less than 7 days from symptom onset. If we started the drug earlier, even if you did combinations, certainly, but if you didn't do combination and you were at 17 patients with kaletra, the mortality of 0 is pretty good, if you ask me. So we don't use it because other things are out there, but it's sort of weird. Why don't we use it early on? What is not true about kaletra? The Society of Critical Care Medicine now recommends against the use. This is sort of like a conspiracy based on that one study. In vitro activity against SARS-CoV and MERS-CoV, but data in SARS-CoV-2 was limited. That's true. NIH recommends against the use of this HIV protease inhibitors, except in the context of clinical trial. Just so you know, the other drug, Prescovix, which is similar to kaletra, it's once a day, was in a clinical trial in China, and it was dropped. The trial was dropped because of that kaletra trial. I spoke to the PI. At least no issue with other PR or QT interval prolonged drugs. That is the right answer. And thank you for listening. You should know the Infectious Disease Society actually does not recommend against. They just say you should use it in the context of a clinical trial.